The number of confirmed COVID-19 cases in South Africa has increased by 52 to 202. Some of the latest cases are from the Free State and had attended a church service in Bloemfontein. Health Minister Dr. Zweli Mkhize says they're trying to trace the worshippers who were in contact with the patients. Well, Professor of Vaccinology at the Wits University, Professor Shabir Madhi, is also the Director of the Medical Research Council of the Respiratory and Meningeal Pathogens Research Unit. And he joins us now via Skype for more on this. A very good evening to you, Professor. Thank you so much for joining us. First of all, the WHO says the fear that COVID-19 would reach countries with weaker health systems. I mean, is the organization perhaps spreading panic in those countries, or is it really a reality that we have to come to terms with?
No, I don't think they're spreading any sort of panic. I think they're speaking to the reality that the virus generally doesn't know any boundaries, especially when it starts seeding in different regions of the world. And I think what we're facing right now is widespread dissemination of the virus. And it's very likely that the only reason why many countries are reporting very few cases on the African continent is simply because they don't have adequate surveillance and diagnostic tests to actually detect the cases.
Now, we've also been advised to drink water regularly. In fact, we've been told to drink water every 15 minutes to sort of help keep the mouth moist and will ostensibly help wash down the virus into the stomach, wherein it'll be dissipated by the stomach acids. Any credence to this theory, Professor?
None at all. None at all. So the reality of this virus is that the manner in which it enters the body is that there are certain receptors which are found on the mucous surfaces, including at the back of the nose, including on the tongue, including in the eyes. And the virus actually attaches to those receptors and then enters into the body. Drinking water, drinking hot water, drinking alcohol is certainly not going to be of any relevance in terms of protecting from getting the viral infection or from the viral infection.
Now, medical practitioners also tell us that face masks don't actually work. In fact, they are not even a guarantee that you won't get sick. But more often than not, Professor, we are always exposed to people who are reckless and don't close their mouths when coughing or sneezing. We certainly cannot overlook the importance of face masks.
So I think the reality of face masks is that there is no evidence that a face mask actually works. And in fact, a face mask might actually put you at heightened risk. And the reason why is that when a person sort of controls the face mask, the manner in which they actually touch down the surface might be contaminated, might inadvertently result in actually infecting themselves with greater likelihood. The main reason for a face mask is actually for individuals that are actually coughing, to prevent them from transmitting the virus. There's a number of ways in which the virus can get into a person, both in terms of through the eyes as well, so not just through the nose and the mouth. And most important is that the main modality of infection of a person seems to be by way of droplet spread. It means that your hands come into surface with contaminated surfaces, and then touch the surfaces, and then you sort of wipe your eyes or wipe your nose or mouth, and you self-inoculate yourself. So while a mask will perhaps protect you to some extent if someone coughs directly into your face, but most people will probably get infected because of contact with contaminated surfaces rather than because of someone coughing directly into the face.
So you don't advise that we should start using face masks as a preventative measure?
So,
and is it also true that this virus can actually filtrate those masks?
Well, it depends what type of a face mask you use. So there's a special face mask which is known as an N95 mask, which we really shouldn't be using because it's really meant to be for people that are going to be involved in terms of the management of these cases, the frontline healthcare workers, and there's a shortage of that mask. Masks that are available don't necessarily protect a person from transmitting the virus, but like I said, more important is that there isn't any evidence that face mask will protect the average person from becoming infected. What is much more important is hand hygiene in terms of avoiding contaminated surfaces and regularly washing the hands when touching any surface, both in terms of washing or also using a sanitizer. Using a face mask is almost a sense of using a false sense of security, which can eventually be harmful to that individual.
So how long does this bacteria stay on surfaces? I mean, the reason I'm asking this question is that I don't foresee so many households in South Africa disinfecting each and every utensil in the house, disinfecting TVs, disinfecting stoves and sanitizing bathtubs, every item in the house.
Yeah, so I think that's a fair point, and we're not asking everyone to sort of disinfect every piece of furniture or utensil in the house. The disinfection really comes into play is in places where there's a person that's infectious, that has contaminated the environment, and in that particular instance, what needs to happen is that there needs to be cleansing, and there needs to be what we call social distancing that's practiced, where people sort of avoid that person in his immediate environment. It's easier said than done, and that's the reason why the government is also looking at different strategies in terms of how best to isolate individuals that are infected, as well as individuals that are in contact with someone that has been infected. So you correctly point out, it's easier said than done in terms of being careful about having not a sterile environment, but rather an environment that's not very contaminated. But there are other measures that one can take place. There are other measures that one can sort of practice, which would reduce the risk of being infected.
You know, Professor, what's worrisome is that, just a week after the president has made a declaration that all public gatherings, including more than 100 people, are now suspended. But then I just took a drive the other day and drove around the city center, and I saw, so many people at the taxi ranks. And it's very, very difficult for so many South Africans to heed to that call. As a matter of fact, in as much as they can take all the necessary precautions, like carrying with them the hand sanitizers and, wearing face masks. But there's just no way of avoiding contact, especially when they are in congested areas like a taxi rank.
Yeah, I think that's absolutely a good point. And it's not just about being at a taxi rank, it's also being in a taxi where there's 15 to 20 people sitting in a taxi, and it just requires one person to be remotely symptomatic or remotely ill, and they could very well, within a quarter of half an hour journey, infect everyone else in the taxi. So it's much easier said than done. It might come to be that at a certain stage in the epidemic, we might need to do what we call complete lockdown of the country. We are to be as successful as South Korea or as successful as China in terms of containing the epidemic. And that might really need to happen, at least in certain parts of the country, where there's a high density of cases. So you correctly point out, avoiding crowds is a really difficult thing to do in a person's day-to-day operations. But we're going to need to take it as the epidemic evolves. We're going to need to take it step by step in terms of deciding how much further we need to go to sort of minimize contact between individuals.
I know it may be difficult to say, Professor, but then how would you advise so many South Africans who use the public transport system? How would you advise them to stay safe?
Look, at this stage, there aren't any options. As you know, there's simply no options. People need to get to their place of work, and that is the reality. People need to get to hospitals, and they take public transport, and that is the reality. So right now, the most important thing is you need to avoid people that are coughing. And if you get into a taxi, as an example, and again, it's easier said than done, but if you get into a taxi, you're touching the seat, you're touching the part in front of you, the virus can survive in those places for up to 2 to 3 days. So you're coming into contaminated surfaces. You're potentially coming into contact with contaminated surfaces. And the only way that you can protect yourself is by trying to practice hand hygiene. But like I said, it really depends on what happens in the next few weeks, which will determine what additional measures need to be put into place to try to interrupt the transmission of this virus in the community.
Is the COVID-19 more dangerous than flu? I mean, so many individuals who get coronavirus will experience, the regular, and seasonal flu symptoms, but the overall profile of this disease it looks far more serious.
Okay, so it depends in what context you take it. So as an example, with seasonal flu, each year about 1/3 of the population become infected with seasonal flu, but not 1/3 of the population becomes symptomatic from it. Roughly about 1 to 3% of all the people become symptomatic and have sort of a fever, a cough, a sore throat, etc. All that 1 to 3% that become highly symptomatic from the flu infection, the mortality rate, the percentage of people that will die, is about 0.1%. Now, when it comes to the SARS coronavirus 2 or COVID-19, From what we understand at the moment, there's no country in the world that has currently reported an attack rate of symptomatic illness of more than 1%. In Italy at the moment, the attack rate for the whole of Italy is about 0.06%. In Wuhan, which was the place where the transmission started, the attack rate was roughly about 0.5%. Now, the reason why these numbers are important is that it tells us in terms of how many people would be potentially infected in South Africa. But unlike flu, where the mortality rate is 0.1%, for coronavirus, the mortality rate is between 1 to 3% and higher in certain age groups. What really concerns us is that even 1% of the population being infected is a large number. And even if the mortality rate is only 1 to 3%, that all accumulates to large numbers eventually in terms of the number of people that would actually die. So it really depends on how you look at the data, how you look at the numbers, which determines just how bad it's going to be.
You know, we've seen in the past week, Professor, the Department of Health at pains trying to fend off various fake news and misinformation or disinformation that with regards to coronavirus, some of the myths to the effect that it only targets white people, it is a white man's disease, and some of the myths to the effect that it only kills the elderly so younger people can relax. So now that we have established by all means that it affects just about everybody despite race, despite nationality. So what about the assertion that it only targets the elderly?
Okay, so it's not that it only targets the elderly. Anyone in society that comes into contact with someone else that has got a coronavirus and that's symptomatic is equally likely to be infected. So the infection rate is irrespective of age, it's irrespective of race. The difference is that the elderly, people especially over the age of 70, 75, are more likely to develop severe disease. And when they become symptomatic, they're more likely to die. So if someone over the age of 70 develops symptomatic illness from the infection, their risk of dying is between 14% to 20%. Whereas someone who's healthy otherwise, a 30-year-old person, if they become infected, their risk of dying is closer to 1%. So it's really a difference in terms of the risk of dying after you become symptomatic, rather than the virus infecting the elderly differentially from other people in the community. The other point that you raised in terms of race, I think we need to be careful how we interpret the data. The reality in South Africa at the moment is that the majority of individuals that have been diagnosed are of Caucasian descent. But the reason for that is because 95% of the cases right now have really been diagnosed in the private sector and predominantly amongst individuals that have got the means to have traveled overseas. And that has got a certain demographic profile to it, which happens to be predominantly white people. Now that we're beginning to see community transmission of the virus, what we're going to see an increasing number of individuals that are coming from other races, and especially when there's greater testing in the public health sector, we're going to see that profile change completely. So there's a very biased view in terms of what the virus is currently doing, because of the biases that exist in terms of who has been tested, who has been able to afford to access testing, rather than the reality of what the virus is probably doing in our society.
Well, Professor Madhi, thank you so much for your time. Much appreciated. We do appreciate your insights. That was Professor Shabir Madhi, the Professor of Vaccinology at the Wits University. He's also the Director of the Medical Research Council, Respiratory and Meningeal Pathogens Research Unit, speaking to us live via Skype.